Yes. So what's the problem with intertrochanteric fractures? Well, there's not one. There are actually too many problems. One is that most of the patients are very elderly. The bone stock is very, very poor. There's a lot of comminution at the fracture site. The patient compliance as regards mobilization is very poor. So you can't really give them instructions like partial weight bearing, toe touch bearing. Most of them will take the weight just as they can because they're not able to balance themselves. And there's a hell of a lot of weight which goes through the fracture site, and there's a lot of force which happens, and you can't really reduce it. Even things like an SLR moving the hip across to the bed actually causes a lot of weight to go through. So malunion definitely happens very often, and it does cause fair amount of issues. Remember, implant failures are not that uncommon. So host of problems which are there, but not to be in total despair. There are a few good things about intertrochanteric fractures. One of them being is that the vascularity is rather good. The patients are normally not as demanding. So you'll get away with murder in quite a few people. And union, remember, is fairly common. So it's unusual to get malunion, to get a non-union. See the incidence out there? It's just under 5%. So it's 2 to 5% what is reported. But the incidence of malunion is quite high. Now, just have a look at the slide again. So the overall complication rate remains about 20%. Remember, as Dr. Malhotra said, 1/3 of them are almost going to die within a year. So you really need to make sure you do one surgery, do it well, give them back whatever quality of life they have. And implant failure rates are very, very high in this kind of a thing. So the reason why you get a lot of malunions is the amount of muscular force which is there. So I know I'm showing a photograph of a subtroch fracture, but the forces are fairly similar in both. So it's the glutea which are going to abduct, the iliopsoas which is going to flex and rotate externally. Then you have the short external rotators which are again going to cause a rotational element of stress to the trochanter while the head remains in position. So whether you treat it non-operatively, operatively, the forces are going to be the same, which need to be counteracted by whatever you do to it. So these are the kind of X-rays which you're going to see. So you can see the amount of shortening which is there. You can see the foreshortened appearance. The trochanter is actually gone behind the neck. The lesser trochanter is quite prominent, just showing the amount of external rotation. And this is what happens even though you've actually reduced it well, you fix it well. Look at the amount of resorption that is happening. So pretty much this is what happens, and that's what you get malunion happening at an incredibly high rate in this. So what you're going to end up with is a limb which is shortened, the limb which is externally rotated, and the hip which is in varus. So whether you treat it operative, non-operative, obviously I think most of you know that operative option is the way to go. The limb can be short by a little bit or a lot. They can be varus. And most of the patients, as you can see on the photograph on the right, will keep their legs externally rotated. So the biomechanics happening because of all of these. There's an altered rotational alignment because the hip has gone to external rotation. There is a coxa vara, and remember the offset is decreased now. So the offset decrease is going to cause a reduced abductor efficiency, which I think we've gone over this now even in the past few presentations, is going to cause the difficulty in walking and standing and early fatigue. So people will tend to get tired out. Once they've done a little bit of walking, a little bit of standing, they'll tend to tire out a bit. I don't have to go over the diagram again with you, but just to tell you that the problem you're going to have there is what this lever arm, and this is going to remain constant. What you're going to be having is a smaller lever arm and the abductors which are not actually acting through their normal length. So it's a shortened out length of the abductor, which makes it more inefficient to move. So in all, this element is going to give you a Trendelenburg element, both in the gait and a Trendelenburg sign, which is to say that this hip is not going to be operated. So as you can gather from the past talks that you had, you're going to get a Trendelenburg lurch, a Trendelenburg gait, and a patient will be limping from side to side. So when you come to do a clinical examination, when you're looking at the gait, you're going to have a combination. Remember, we just gone over that. Trendelenburg with a short limb element. You got shortening and the abductor insufficiency. When you see the patient standing, as we've just been told, you got to look at the shoulder and the patellar level for the level of the scars. When you ask the patient to sit, remember LLD is what you're looking for. So you can have a look at the Galienzi sign. You can do it sitting, you can do it lying. But both ways, it's the same thing. When you do an examination, lying down and you have a look at it, obviously you're going to look at the attitude of the leg, and the leg, as I said, will be externally rotated, and you're going to have some amount of shortening, which you can see, and it's going to be a true shortening. And remember, you got to actually measure the amount of shortening which is there. Do comment on the level of the patellas both, and look at the surgical scars in the present age. It's unlikely to see a patient who doesn't have a surgical scar somewhere or the other. After, normally the range of movement is reasonable, provided that he's not gone into a non-union. But the arc of movement can be actually different because of the external rotation, the internal rotation can be either not there or very much reduced. But the amount of external rotation will almost sort of maintain the arc of the movement. When you come to do a special test, the Bryan's triangle, which is going to do the show you the shortening is going to be altered because the equilateral triangle will not be formed. Another thing to look at is the torsional profile. When you look at the torsional profile, you'll have to distinguish whether it comes from the tibia and the femur. I'm talking about a normal case. So if you have all the whole limb, you can look at the foot progression angle, which is shown in this. When you draw a line, 1 foot goes out, 1 foot stays in. So you can have an outgoing and ingoing, and obviously it's going to be asymmetrical. When you look at the femur for a rotational malalignment, you can have the prone test, in which you're going to have a look at the internal and the external rotation, and depending on the movement which you've lost, you can actually see which way is the rotational malalignment. If you're just looking at the tibia, this is more for the sake of completeness. Then you actually make the patient prone, knee flexed, look at the long axis of the thigh, long axis of the foot, compare it to the opposite side. So here you negated the femur out totally, and you can only have the tibia, which can actually give you this kind of a problem. So is this been proven out in literature? And very much so. So most of the literature will tell you about the high chance of abductor weakness, and also that it takes a long while to actually get better. So who gets it? Who gets it more? Who gets it less? And the answer is, the older you are, the higher the degree of comminution. The treatment modality, whether you put a sliding screw, whether you put some screws in, or you've done a PFN, actually makes a difference. And you can actually show that the intramedullary nail ones have lesser chance of collapse compared to maybe a sliding hip screw. The stability of fracture hence comes into force. And if you look at the OTA classification, these are the ones which are much more likely to have more significant shortening, more malalignment, and cause you more problems. The other thing to look at predictors of malunion would be what is happening to the posteromedial aspect, which has been well looked in the literature. So that's a posteromedial fragment. There's a look from the back. So the size of the posteromedial fragment, the amount of comminution which is there. Another way to look at it is what is the thickness of the lateral wall. That's Gottfried's article, which I'm talking about. A good article to read would be the George Hadukovich article, I think is 2009, which looks at the 10 tips to improve the result. So now we come to the solution. Now we know that we have a malunion problem. So who do you have to approach aggressively? Who do you approach gently? The answer is, look at the functional impairment. You'll be very surprised how some people are managing so well. And remember, it takes a while to recover from this. So don't rush it. The younger demanding patient, obviously Russian, if he's already having a collapse, he's going to do badly. Definitely get in early and try to do something about it. So this is an 82-year-old Sikh gentleman, comes from Punjab, walks into my clinic, and I look at him and he tells me about this pain, and he has this very vague kind of an history. And I almost thought there's nothing wrong with him, but then I just thought, there wasn't the comparison of the two legs was showing that both of them had the significant leg length, both had a significant external rotation. I just thought, oh, I should get an X-ray. And there you see it. I mean, this guy's kind of walking in. So he's compensating for his malunion because he's matching up both the sides. So there was no point really offering him anything. And I said, look, you're doing too well. I don't think I can make you any better. So when you have to come to think about an operation, you're going to require, as Dr. Madhu said, something like a valgus osteotomy in the more younger one. Remember, the head and the neck is much more likely to be intact compared to the non-union neck or femurs. So this is actually easier option. Remember, union is not that much of an issue. So valgus osteotomy may be more better out here compared to say a neck or femur. So you have much better results with this. But you would consider hip replacement, obviously in the very elderly, the very old kind of stuff. Remember, always check the re-rotation. So you might have to dial an element of rotation into it. And there are lots of things giving up. You had a much better person talk about it, so I'm not going to go. Just to say, you need a torsional profile, which you can check, or you can do a ballpark figure of rotation or something. So how do you do it? You can do it with a DHS, a simple DHS, a 130-degree DHS can actually do the job for you. You can also do it with a blade plate. You can also do it with a double angle. So there are lots of options for doing this. So here's one case which was done earlier by one of my colleagues. So you can see that non-union, the patient was offered, very elderly person, patient was offered an operation. He didn't want the operation of a replacement. He said, do whatever, but I'm not going to have a replacement. So this was done. And again, may I say, and I admit to it, not fully well done, rarely. And then eventually it collapsed, and he was never really a good candidate, given not all of his other medical issues. And that's what he ended up having. But, you can actually intervene early depending on, so that was one element that you need to look at about quality of bone, how good you are at doing these things. So the other thing, decision making, is who requires an early one, who doesn't require an early one. So what I would say is, say somebody like this who walks in at about 2 months, the implant is holding on, and you know that around 2 months he's like to be healing, he's slightly on the elderly, that's not the time to get in. You can actually let him walk on it and see if the pain settles down. So maybe you don't have to do anything about it. So this man, I would rehab it at this stage. But look at this guy. He's about 33-year-old. He's had a fall down the steps. Somebody's gone ahead and put this nail inside. But immediately you can look at it. He's obviously got a coxa He's already got a shortening. He was told to wait it out a little bit, more bed rest, more so walking and everything. So when he comes back to me at about 3 months, now at this stage, his fracture should be on the verge of healing. I can't really see the point in operating him now. He's just started to walk. So in my opinion, I would have said wait for the time being, but I've told him he's very, very likely to, his socioeconomic status is slightly poor, very likely that he will need a valgus osteotomy because he's that young. This kind of a thing in implants, walking out, you need to do it as early as you can. So this is somebody who's about 72. So he's been walking using a walker, cannot actually get better than this. Now this guy needs a proper valgus osteotomy. That's what it's done, and it seemed to heal up in no time and got him
Dr.
walking.
Gurinder, 1 minute more, please.
That's wonderful. So we'll be done. So this kind of a thing, and the implant is cutting out through, it's eroding. A total replacement makes a lot of sense. Lots of literature to look at if you want to look at and follow up and the results and everything, and also a lot of literature to talk about how the amount of collapse has a direct bearing on the physical functioning, social functioning, and a huge thing. So this, if you really want to know how bad you can get, this is a great paper in Journal of Orthopedic Trauma. Essentially, it shows us your gait is totally altered once you get this kind of a thing. To summarize, it's a fairly common thing. You got to pick the unstable ones and preferably do a nailing. Not all malunions will require a treatment. So who requires a treatment is an assessment you need to do for the patient. But whatever you do, mobilize them early. Thank you so much.